I'm excited to welcome to the studio Jeremy Cannon, Chief Nursing Officer at Kalkaska Memorial Health Center. And I'm not going to ask our listeners to spell Kalkaska, but I am excited to have Jeremy in the studio today. And we have a lot to talk about because nursing has changed in the course of the last decade.
Absolutely.
I think nursing's changed in the last 2 years.
Yes.
But we'll talk a little bit about that for our listeners to gain perspective of how does rural health deal with some of the challenges in nursing and in services to rural communities with limited resources. You're experiencing, I would assume, what everybody else is, but I'm going to let you tell us that. And so let's first start so our listeners get a little bit better understanding of who you are. So why don't you take us through your journey? Where'd you grow up? Where'd you go to school? Where are you now? What do you do?
Yeah, so thanks for having me. Yeah, I grew up in the Upper Peninsula of Michigan, about 25 miles south of Marquette, so full-on Uper, and I'm proud of it.
Yeah. So for those that are listening,
Yeah.
From throughout the country, they understand Michigan is divided by a thing called a bridge.
Yeah.
So you're above the bridge.
Yes, I am.
By about how many hours?
So above the bridge, I was about 2.5 hours from the bridge.
2.5 hours,
yeah,
okay.
where I kind of grew up. So
all right. And I think you call us the trolls.
You're the
Is
trolls,
that right? Because
yep.
we live under the bridge.
Yeah, and then
Okay.
we're the Upers because
You're
it's
the Upers.
U-P-E-R-S,
Yeah.
Upers. So
Yeah. Now I spend a lot of time up there
Yeah.
when I go because my son went to Lake State.
okay,
And so we have to search for rocks.
yeah, absolutely.
And there's all kinds of rocks, but the rocks that light up at night,
Yeah, the Uper lights.
the Uper lights.
That's right.
So I had to spend many nights with a flashlight, not just any flashlight,
Oh no.
looking for rocks. But beyond that, you have a beautiful community up there. You were born there,
Yeah, absolutely.
raised there, and you decided to go to college where?
Northern Michigan University.
All right, so Northern Michigan.
Yeah, yep. Went to nursing school there, graduated, and then did everything they tell you not to do and moved below the bridge, Took my first job at the Regional Referral Center in Traverse City, at Munson
Okay.
Medical Center. I started there as a bedside nurse and then went into leadership after 2 years and managed a 21-bed med-surg unit. Then a couple years after that, became the director of nursing operations and throughput. So I had 300 to 400 FTEs kind of under my sphere.
And this hospital that it was owned by Munson, or is
Yep.
owned by Munson, and is it the regional hospital for that community?
That's correct, yes.
Okay,
Yep.
so big operation.
Yeah, 400-bed operation.
400 bed.
Yeah, really covers
Wow.
pretty much the entire northwest corner of the Lower Peninsula.
Yeah.
And so, learned a lot in that space. Had graduated from Ferris State University with my graduate studies in nursing and in business, and
great.
have some young children. And my wife was like, I think if we're going to make a move, this is kind of the time that we're going to consider doing it. And, didn't really have anything on my radar, but always in my heart, have loved the Upper Peninsula, loved rural spaces. And my wife thought, maybe you should look into some rural healthcare. And so I just happened to start looking. And the next thing that happened is the first CNO position at Kalkaska Memorial Health Center was opening up,
Wow.
which is about 35 miles from where I was
Yeah.
currently working.
So you're like, wait a minute, the stars may be aligned.
Yeah, every once in a while, everything kind of comes together. So I started that role in February of 2020. 2 weeks later, the pandemic happened. And so I received quite the orientation when it comes to
Sure.
getting into senior leadership team in a rural space. But
Oh, yeah.
it was
You're
absolutely
everything
incredible. Oh,
at
yeah.
that point,
you
you
learn.
know.
Yeah, you learn in a hurry. You have no choice. So
Yeah. So you started at Kalkaska.
Mhm.
Now, tell us a little bit about Kalkaska's health system. What does that look like? What does the ecosystem look like?
Yeah, so we're an independent facility, community owned, and I know we'll talk a little bit about kind of what that hospital structure looks like now. Eight inpatient beds, diverse and services, very robust primary care, 104-bed long-term care facility, ambulatory surgery, radiology, rehab, very, very robust emergency department, about 17,000 visits a year in that space, and then the 8 inpatient beds, pharmacy, and just a slew of other things, dialysis.
Yeah.
We really kind of, I would say, focus on senior services. We're really committed to the
Okay.
senior service
Okay.
line.
So your community up there, what county are you in?
Yeah, so we're in Kalkaska County. So we are about 35 miles east of Traverse City. So we're, on the probably the upper half of the northern Lower Peninsula.
Okay.
And only people in Michigan can say that.
Would even understand what that
Yeah,
even
right.
means. So then the community that you're actually practicing in right now,
Yep.
that your hospital is, how big of a community? Give
Yeah.
our listeners a sense of that.
Yeah, so we're about, the county's 17,000
Okay.
people in there. So yeah, we,
So small.
Small county, yeah, definitely small. Surrounded by some larger areas, urban areas. Traverse City is a growing space in Michigan.
Yeah.
We have Cadillac to the south, Gaylord to the east, and then Petoskey to the north. So we're about 45 minutes. We're surrounded by 4 larger facilities, 45 minutes in any direction.
So 45 minutes in any direction. Jeremy, do you do OB?
We do not do OB.
Did you have it at one point?
A long time ago, I heard there's people I work with that said they were born in the hospital.
Oh, wow.
Yeah, it's grown a lot. It used to look like a gas station on the side of the road, they say. But
oh, my goodness.
So we've seen some significant growth.
That's
but no,
awesome.
The OB services are done at those regional facilities.
Yeah, and it's hard. So before we move on to the meat of our discussion today, do you have an interesting, we like to ask this question, an interesting fact about, our guest, because our listeners are like, all right, let's humanize this.
Yeah.
Do you have an interesting fact about yourself?
Yeah, I was thinking about this. I'm probably the most boring youper ever, but I'm just, to me, I think, I'm super proud of where I grew up. I'm super proud of being from the rural space.
Yeah.
It's so funny because I used to, when I was at the bedside and I always took care of people, I always led with, oh yeah, I'm from the Upper Peninsula. And they look at you like you're Bigfoot. Yeah. And they're like, oh, I know somebody from the Upper Peninsula. And they're like,
they'll tell the story. He's a lumberjack.
Yeah, they're 15 years older than me and live like 3 counties over.
Exactly.
Like there's only 7
of us
up there.
He only comes out twice a year.
Yeah. Yeah. So that was always my kind of my lead to. But I mean, I think, there's something really trusting about being from the Upper Peninsula. Yeah. And so people automatically gravitate towards you and are just super interested because it's, they think
it's a different world, though.
Yeah, like you haven't seen the sun in 6 months, and
well, that does happen a little bit.
It's true, absolutely, yeah.
But it's such a beautiful area,
absolutely,
and certainly people flock there during the summer.
Yeah,
and I'm sure you get a tremendous amount of winter sports with snowmobilers.
Yep.
Does that keep your hospital busy in the winters? Or?
We used to really say things were seasonal, but honestly, it's become, there's been this move towards the rural space, especially post-pandemic, and there is no kind of peak season. It's pretty much peak year-round now.
Yeah.
It's really a desirable place for people to live and receive health care.
Yeah.
And so we're really not seeing that seasonality anymore. All 4 seasons are full tilt in Kalkaska County, and we love to enjoy all of them.
That's awesome. To sustain high-quality services in our communities, hospitals have relied on and have to think outside the box for creative community-based solutions. Jeremy is here to share his experience bringing health services to a rural community in northern Michigan. We'll talk about community partnerships, building a talent pipeline for our healthcare workforce, and, of course, what does all this have to do with rural health? So let's talk a little bit about, when we think about a critical access hospital, people think that it's just limited, right? You can only do so little things. You've already explained to us you do a lot outside of what many critical access hospitals don't have long-term care.
Mm-hmm.
It's becoming more popular, I think, but as a generational shifts.
Correct.
But what would you describe in your community as a primary challenge and an opportunity where you are right now?
Yeah, I mean, I think, critical access hospitals, I didn't have a ton of experience with it either when I started. I learned a lot transitioning over. Even when I did my clinical studies in nursing, they were always done at a regional facility. So even growing up in a rural spot, I didn't really have, a ton of opportunities to experience the rural space. When I think of, start with opportunities, because I always love the opportunities,
Sure.
is that there is a real push for people that want to live in the rural space now.
There is.
People are kind of becoming a little tired of the hustle and bustle of the urban life.
Yeah.
So we're seeing a lot of people coming out there, and so it's provided a lot of opportunity for us to expand our services as there's a an increased desire to kind of go out to that space.
Mm-hmm.
I grew up in a small place where access wasn't always an opportunity for us, and so as I've gotten older and realized the importance of healthcare, I've definitely tried to recognize that people here are working hard.
Mm-hmm.
They're doing the right thing, and they should have access. So I think that's really kind of what drives us as an opportunity is we look at every opportunity there is to provide access for all of our
and that's hard.
Yeah, it is
right?
very challenging.
Because good luck recruiting providers to rural and then northern rural
Absolutely.
America. That's hard.
Absolutely. And I think that opportunity, but then the next piece is the challenge, and the challenge is the financial part of it, right? Everybody's kind of dealing with the same thing, the financial, uncertainty of what it could look like here for the future. And, you have a commitment, some of these rural facilities really are the economic drivers in their communities.
They are.
And so when you're thinking about adding, subtracting services, I mean, it has a ripple effect and potential generational impact.
It
So
does. Absolutely.
you know,
does.
those are kind of some of the biggest challenges around the financial. I think the financial one is, to your point, workforce, you know, making sure, you know, we can be competitive to recruit and retain. Also, technology is going to become more and more of a thing as technology is only getting smarter. I say that all the time.
Absolutely.
And there's a huge
And we have to be ready for it, right?
absolutely.
A lot of communities are still struggling even to get infrastructure
Yeah.
for it, and that's a challenge.
Yeah.
Do you experience that in your community?
A little bit.
Broadband, internet, those things kind of difficult?
Yeah. I mean, I think that we've made a push in the last couple of years. I think everyone is really recognizes the importance of it.
Good.
But yeah, there's still some definitely significant gaps where we're at.
Yeah.
And so, you know, IT is expensive. It's only going to probably get more expensive.
You're right.
By the time some of the stuff, you know, you can afford it, it's already obsolete.
It
So you
is.
just got to stay with it.
It is.
But those are kind of some of the biggest things. You know, again, the financials is always going to be the challenge. You know, there's probably likely never ever going to be enough money
Never,
or
never.
a robust amount of money to make all the things happen.
Yeah.
And you want to do what you can to support your community. What housing needs, cost of living,
Yeah.
daycare. I mean, those are all real challenges out
real
there.
issues today.
Yeah.
You know, so my wife was a chief nursing officer, and she often reminded me of that is probably the most pivotal role in healthcare. We argue about whether it's CEO or CNO,
Sure.
but at the end of the day, she always wins.
That's smart.
So CNO, you know, plays a very critical role in influencing patient care
Absolutely.
at hospitals. You set, you know, the clinical acumen of sorts for the entire organization, which bleeds down into the community. What type of care can I receive, or should I expect to receive? So there's this issue called social determinants of health, and you and I both looked at that from an MHA perspective,
Yep.
as well as in our industry. And you know, the challenges of going on, you know, the outside of our four walls of our hospital. As you have to do. How have you done that to influence your operations and planning for the future as you look at social determinants of health?
Yeah, so, you know, prior to my role in rural, I really only thought about the four walls of the hospital. Once I got into the rural leadership, I recognized the importance of it. You know, and then, you know, post-pandemic, I feel like all of the challenges that were there were just exacerbated.
They sure were.
And so, you know, what we've done is really kind of looked at opportunities to keep people out of the hospital, which is counterintuitive when you think
Yeah,
about,
it
you know,
is.
you're the
It
leader of a
is. I know.
hospital. Like, how do you
Yeah.
keep people out?
It's hard to understand that as a CEO.
It is.
Wait a minute. I don't want people in my hospital?
Yeah, and explaining to your CFO is even more challenging, right? But
You bet.
you know, when you're aligned as a community and
Yeah.
a board and a hospital about the quality, you know, improving the quality of health and life for the people that you serve, it really kind of just goes hand in hand. So what we've done is around community paramedicine has been one of our big opportunities, right? So we, you know, when we see people in the hospital, they hear the word "you're going home," and then they just kind of shut down and they're checked out.
Yeah.
They're already thinking about how do I get back.
Yeah.
So we use community paramedicine as a way to kind of help bridge that gap between home and the hospital to try to keep them from coming back to the hospital. You know, the other thing that we've recognized is when you look at an emergency department, it's probably one of your most expensive, you know, cost per square foot.
Sure.
You know, and if people are already challenged as it is, it only takes a couple co-pays in an emergency department to really kind of determine whether you're going to pay for your, you know, you're going to pay for your food this week, or you're going to be able to buy gas to get to your next appointment. So we use community paramedicine as a way to kind of really help bridge the gap, keep people at home, and, you know, hopefully get them lined up with more appropriate services. There are a lot of things that, you know, when you're taking care of patients to the bedside, they're not disclosing.
Yeah.
Community paramedicine is able to go to the house and say, "You don't have water?"
Yeah.
And nobody really asks that question, right? So what we also have done to kind of bridge that gap is partner with our local health department, and we fully fund a community healthcare worker in our space. And so the community healthcare worker really looks at it from the social spit, you know. So the community paramedic looks at it from the medical eye, and they don't have necessarily the resources and everything that it takes to really understand how to solve the food insecurity issues or whatever else. The community healthcare worker then kind of takes the handoff, and then they help, you know, get these individuals aligned in programs that they're entitled to. What we've recognized from that initiative is that individuals that have accepted services and are working closely with the community healthcare worker have an 80% reduction in their ED utilization 6 months after they accepted services compared to the 6 months before they accepted service. So, you know, those are, again, you know, from a, you know, it's really hard to explain that in a tangible way about, you know, from a financial perspective, but like, we know, like, if we're going to do this right and we're going to really care for the community, like, we need to be doing some of these non-revenue, non-billing strategies, because it's really about caring for our friends and families.
Yeah. So let's talk a little bit. Let's get into the weeds here a little bit. So that sounded amazing.
Yeah.
Put it into practice.
Yeah.
So tell me, I'm patient X.
Yep.
How I'm going to benefit from that community program.
Yeah.
So I present to the ER.
Mm-hmm.
Take me through how you're keeping them at home. How does that work?
Yeah, so a lot of times what we see is we see people that will come into the emergency department and then they want to leave AMA because they have a family member, AMA, against medical advice. They have a family member at home they got to care for. They got a pet. They got something going on. And the provider's like, oh, I don't know, this isn't really a good idea. We're not going to hold anyone hostage.
Sure.
So that's, kind of one avenue where we're like, oh yeah, this person we need to kind of bridge the gap and get back with them and make sure they truly understand like what's going on. We have people that are discharged from our inpatient unit as well, that it's like, again, they hear, hey, you're discharged, and then they just go home. Yet they've had this exacerbation of this chronic disease, COPD, CHF, whatever it might be. Same thing out of our short stay rehab and our long-term care. So those are kind of our main avenues.
Yeah.
And then what happens is a referral is sent to our community paramedicine. We have them on site 7 days a week. They're there from 10 a.m. to 10 p.m. And then they do.
What is their degree? What is their background?
Yeah, they're a paramedic.
Paramedic.
Yep. And we own our own EMS services.
Okay, so that's the other part.
This is what
so
makes
so
it
that's
sweet.
what that's where I first learned about
Yeah.
this, is because I attended the Michigan Center for Rural Health had you as a guest speaker maybe 2-3 years ago, up in Schoolcraft, I believe it was, college, a couple years ago, and you presented about that program.
Yeah.
But the one key that I think is important to mention, you own your own ambulance.
Yes, absolutely. And so,
are you the only ambulance company?
there are multiple there are multiple ambulance companies around us, but we fully own our own EMS. We have 5 EMS rigs in the community.
So you're going out on 911 calls.
Oh
the
yeah,
whole 9 yards.
we're doing all of it. Yeah.
So then you can attract paramedics for
Correct.
this program.
Absolutely.
Okay.
And they love it. I mean, they do a fantastic job. It's like emergency services or firefighting. I mean, there's a burnout fatigue that can come to that.
Yeah.
It's really intense all the time, and this allows them to kind of get back to what they really want to do, is care for the community in their most vulnerable moments.
So they're seated somewhere.
Yeah.
In your facility.
Yep, they're seated in the emergency department.
So they're in the ER.
Yep.
And then they do phone triage. They do in-person triage. They do coordination of care.
Absolutely.
And that could be anywhere from getting services that the community needs,
Correct.
the member needs. Correct.
Yep.
And then so how long has that program been in existence?
Yeah, so we've been doing, it's been kind of hit or miss, very ad hoc for the last couple of years, but we've really probably over the last year put it in as a fully 7-day a week. This is what we're going to do. And we've got some incredible stories of times where the community paramedicine went to their house and truly saved these individuals' lives. And again, so the community paramedicine tries to make a connection with them before they leave the hospital. It tries to say like, hey, here's who I am. This is what I'm going to do. Are you okay with that? Sometimes that works out. Sometimes it doesn't. I mean, if somebody comes in at 3 o'clock in the morning, the community paramedicine isn't there.
Yeah.
But then they turn around and they, go to the house and they do an assessment. They do the med recs. They turn around and assess the home, reiterate the discharge instructions. They have full access to the primary care providers, the ED provider, the acute care provider in the hospital. And they kind of tie them up with
coordination of care comes for all that. That's incredible.
Yeah.
So I'm going to put you on the spot.
Oh, you're good.
Do you have a favorite success story?
Yeah.
That you could share with us? I know it's not part of the script today.
No, that's
but maybe say something so that our listeners know. How do we? Does it touch home? Is it real? What is the impact?
Yeah, absolutely. I mean, I think we've got a couple, but there's one that I've shared quite a bit that happened, a couple months ago. We had an individual that came in the emergency department, had some dysrhythmias with their cardiac dysrhythmias, but they had a family member at home, and they're like, I got to go home to take care of them. The ED docs were like, I'm not really sure. Like, yeah, she's kind of borderline being followed up outpatient versus having to go in inpatient. Called the community paramedicine and was like, I need you to kind of go out to this person's house and check on them. So our goal is from the time the referral happens, they go out to the house within 24 hours. They were calling the individual, not really getting through to her. They were still concerned. The community paramedic called the ED provider, was like, hey, I can't get a hold of her. We do the phone call, 1, to make sure it's okay, but 2, to validate address and everything like that. The doctor was like, I just don't feel comfortable. Like, we really, let's go ahead and call the police and we'll do a wellness check at the same time. So they went over to the person's house. The individual was having a full-on cardiac event.
Wow.
Yeah, they got her in an ambulance, got her, to the hospital. She did well, survived the whole kit and caboodle. And, for me, it's like if we hadn't sent community paramedicine and we hadn't done that extra step, I'm
She wouldn't be here.
I'm fully
No way.
sure she wouldn't be here.
No
so
way. No way.
Yep.
It's incredible.
It
So
is.
it's incredible work to watch, impacting your community. Um, Driving down utilization of the ER.
Yeah.
How hard was that to explain to your community, your nurses,
Yeah.
your CFO?
Yeah. No, I think so. The emergency department exists for,
True
real deal, true
emergencies. I
emergency,
agree.
right?
Yeah.
So we started out when I got to the hospital. They're like, "Hey, we are going to renovate our emergency department." Everyone was really excited about it. I was like, "That's great." I had oversight of a 40-bed ED at a large facility, no big deal. Feel good about this.
How many beds do you have here?
We had 7. And so they were like, we're gonna add, we're gonna renovate everything else. Well, the pandemic happened, and we literally tore those plans up and started over.
Yes.
So then we built a brand new 11-bed emergency department. We see multiple patients, and we were seeing lots of people. There used to only be one front door to the organization. So if you came in for your arm was falling off versus a stub in your
This is where
toe,
you go.
everyone goes to the same spot. So while we're going through this, we opened up a walk-in clinic. We're like, this is going to be great. We're going to siphon, the lower acuity volume over, which will allow us,
Appropriately.
keep this throughput going. I'm really all about throughput. And all it did was get backfilled with higher acuity volumes. So we've not seen a dip in our volumes at all.
Okay. Okay.
But we've adapted to the times and the higher
Sure.
acuity, and we've
Sure.
done some great stuff there. And we do fantastic. Our throughput is, our average length of stay is 2 hours. And I
Yeah.
always say, at some other facilities, you don't get out of the waiting room in 2 hours.
Oh, absolutely.
And so, for us, it's about creating capacity and making sure that we have people readily available. So when the
Right.
emergency happens, like there's no infrastructure challenges. And so, there's no business case for it, but everyone can relate to the fact that it could be their family member that has that emergency, and we want all resources and infrastructure available if
Yeah.
that comes to fruition.
Man, you're doing a phenomenal job up there. I was encouraged a few years ago when I sat through your presentation about community paramedicine because I didn't know much about it. I'd heard about it, but it's very impactful,
Sure.
and you're a community that certainly can speak volumes to it. Communities like Hillsdale and other communities throughout the country that are listening, we don't have access to ambulance. And that becomes a little bit of a problem with implementing programs like this,
Yeah.
is that good luck even getting, a paramedic to your community.
Yeah.
And that's a whole nother episode we can talk about is, paramedics and that whole industry that's being shook up right now, much like ours,
Yeah.
under some of the legislation that's happened. But I want to transition our conversation
Absolutely.
a little bit because across this nation, we are struggling with nurse recruitment. And to a certain extent during the pandemic and shortly thereafter, nurse retention, because we had a lot of competing organizations that were offering $30,000, $40,000, $50,000 sign-on bonuses, traveling agencies that were offering $50,000 sign-on bonus, free housing, and like $70 an hour.
Yeah.
But we were being charged that as hospitals, and
Yeah.
we still have travelers here today because it's so difficult. Talk to us about this issue that's plaguing our nation. Seems to be far less recruits coming out of nursing school. We have a generation that's retiring. I don't know, maybe you're not experiencing it up there, but we have a major recruitment issue in Hillsdale. And my colleagues that I speak with across the state have the same problem. So what is your approach for, soliciting and hiring nurses in rural northern Michigan? And what advice would you give to other healthcare leaders trying to build that talent pipeline for the future?
Yeah, I mean, it's definitely a challenge. There's no doubt about it. I mean, I graduated from nursing school, 15 years ago, and they were talking about, the shortages that were coming. Well, we're definitely feeling them for sure. I think, for me, it's about culture. Like I talk about the culture all the time. And when you're looking at a lot of the nursing schools, just like mine was, we were going to the large facilities, the biggest facility they had, to try to get as many reps as humanly possible. So the exposure to rural healthcare wasn't there. I've worked really hard over the last probably about 3.5 years to really kind of build a pipeline and give people exposure to rural healthcare. I mean, again, I had no experience.
It's different.
It's way different. I had no experience when I went into my role. I grew up in a rural community, and that's what I knew, right?
Were you shocked when you walked into your 400-bed facility thinking, what
Absolutely.
the world is this?
Yeah, absolutely.
Because it's contrast.
It's a totally different vibe for sure. So what I've done, I've determined that building the pipeline is a marathon, not a sprint.
Yeah.
And we're a society that wants instant gratification. We want things fixed immediately. And that goes for healthcare or whatever it might be. And so, I just have kind of resolved to the fact that like this is going to take a long time. What I've done is get very involved with the colleges. I'm on 4 different nursing advisory boards for
It's
the local.
important.
Yep.
Yeah.
And just be there and be available. Be authentic, which is something that I really, strive to be. And I'm not anyone that nobody different than who I am.
Right. Right.
I took the same licensure exam that they're preparing to take. And so what we've done in Kalkaska is we started a nurse tech program. And essentially what we did is we want to give people, one, it was to expose them to the rural healthcare culture because they're not going to get it otherwise. Most of them live in rural communities.
Sure.
And so that's kind of obviously an attractive. It's like, hey, essentially, we're going to provide, space in your backyard for you to kind of learn how to practice, but you can grow here. And so after their first year or after their first semester of nursing clinicals, they're eligible to become a nurse tech. And then they're usually, they spend 50% of their time at the elbows with a nurse, learning how to be a nurse. They spend the other 50% of their time in a support role. Could be as a nursing assistant, could be clerical, could be employee health, could be anything, right? And we do that for 2 reasons. One, it's a great strategy so that you can see kind of the big picture. We have gaps in all spaces. I tell people all the time, doctors and nurses get all the credit, but it takes a team. Like,
it does.
You don't want me cooking your food for you.
No way. You don't want me doing it.
No good, right?
No
so
way.
it takes everybody. The person that registers individuals is absolutely critical. And so we just really want to harp that, really set that tone for everybody. And then for me, I just tell them it's all about culture. They're going to go to other places and other hospitals, and they're going to do clinicals because we're not doing OB, as you talked about. We're not going to be doing, a lot of critical care. And so, it is different. And I talk about, the culture. The culture is super important. And, every day I'm the exact same person. I show up the same. I give them access to me. And then so they show up for this nurse tech program, and I don't make them sign a commitment. I don't make them say, hey, after you graduate, you're going to, come work for us and this, that, and everything else. I say, if I haven't convinced you that this is a great place to work and you wouldn't want to work anywhere else after 18 months,
I have not.
I've not done my job.
Right. It's absolutely right.
And so we started that with one person. I found one person to go along for the ride with me, and she's fantastic. And so every year it started with, we got one person, then we turned around and we got 3 people to apply.
Wow.
And then the third time we went around to do it, we had more applicants than we did positions.
That's great.
And we talk about not watering down the product. And so right now we have, again, we're an 8-bed inpatient hospital with a variety of services, but we have 10 nurse techs that are in the pipeline ready to go. At the end
That's
of their
incredible.
at the end of their semester, at the last semester, we have 3 touch bases. I meet with all the senior students. We talk about the state of healthcare, what it really looks like, the things that you spend a lot of time learning the technical skills, but like what does healthcare look like, what does the job market look like, and everything else. The second time we meet, we provided them an offer. Here's an offer that's available. This is it. Take it to market. Compare it. Like this is what it is. And then the third time we meet, we talk about the NCLEX and taking their national exam.
That's a big one too.
That's a big one, right? Yeah. And so what we've this methodology, the approach, the culture, we've had 80% of the individuals come and stay with us.
That is incredible.
That is. And then the 20% that haven't have gone and worked at other rural hospitals because they couldn't imagine working anywhere other than rural. And it's all because of the culture. So we do a lot, a conversation around the culture. Even the people that have left come back either as PRN, they stay connected with us.
Wow, this has changed.
Yeah, or they come back as full-time employees, right? So
that's when you've done very well.
Yeah, it's the boomerang effect.
Yeah,
and so again, we can be in any rural community at any time. We travel all the time, and I tell people like, I just want you to be prepared to take care of my friends and family.
That's incredible.
And that's
so with
worked.
with those techs that you have identified and you have them set aside and you're training them, once you have them through this process, help them with their NCLEX, get them through, will your vacancy rate be at like 0?
Oh yeah, it's already at 0.
That's
so
incredible.
We'll actually be at time. We try to overhire because
can I borrow some nurses?
Yeah, absolutely. And they love this facility. There's no doubt. So
Let's talk.
we really, again, we talk about culture and the importance of culture, and we have our admin team and our clinical team, and everybody is walking hand in hand, the community, the board, everybody. So it really is a special place to work. And I think, they realize that. I talk a lot about, the students. I was like, if someone's offering you a $50,000 sign-on bonus, they're not doing it because nobody's rich.
No one is.
Healthcare is not.
There's a purpose in which they're doing it.
Yeah. And so, just to be aware of that and, just be super authentic with them. So, our goal is to grow people. And I tell them all the time, if you want to go be a pediatric ICU nurse, like, I want you to be that.
Yeah.
But we're not doing that here in Kalkaska.
Right.
But I will help you get there.
But we'll help you get there.
And I'll write your letter of recommendation.
Absolutely.
And you'll have a foundation, and you'll have an experience about what a healthy work culture looks like. And I hope you take that with you wherever you go.
Right.
And it's been
so that's
been
incredible.
Awesome.
And you're doing great work. You're ahead of most of us because vacancy rates throughout the state and country are unbelievable right now. So you've built the talent pipeline. I'm going to drop your contact information into our, if we can, on
Absolutely.
our podcast, because I think if other communities can duplicate that, there'd be some great merit. Would you be willing to do that for
Absolutely.
our listeners? Okay.
Absolutely.
Excellent. Now I know we've spent a lot of time talking about specifically what's happening in your community, and I want to ask one more question before we move on to an important aspect of your job, which is advocacy. But the last question specific to your organization is, there's been some recent news that, and I was really surprised to learn that you're not a 501c3.
That's correct.
And so talk to us a little bit about what prompted that change, and what is it going to look like for your community, if anything, any different, or what are the benefits for you?
Yeah, so our hospital was really founded off a public act, Michigan Public Act 47 of 1945, and essentially what that allowed it allowed townships to come together and in counties and kind of pool their resources to start hospitals. And I don't know how many hospitals started in 1945 based off this model, but we are the only one left.
I can only imagine.
Yeah, and so the advantage of you're a governmental unit, and there's different rules.
So you are a government unit
at this point. Yep, we're a municipal hospital, and so what?
And your board is comprised of? I'm sorry to interrupt you.
No, that's where I was going next. So
okay,
we have a 20-person board, which is
sweet night of Israel.
Yeah, which is very large, right? Every township is represented, the village is represented, so that makes 13, and then there's 7 at-larges. But as large of a board it is, everybody in every corner of the community is represented, which is really fantastic. And so again, when I talk about us being kind of like hand in hand, it's the board, the community, the administrative team, the clinical team. We're all moving forward in the same direction. So. Again, back in 1945, one of the advantages was that because you were the way the hospital was set up is that we could go to the community for a millage. We would take that millage, get approved, a 10-year millage, and we could use it for capital improvements. And so that was great. It worked out fantastic. The community tells us what they want. We would receive about $1 million to $1.5 million a year. We would take all that, pool it, and then we would, build business plans around the buildings. So it allowed us to build, more primary care offices. We offer, the community says they don't want to drive 45 minutes for chemo infusion anymore. Great. We check that box. Robust long-term care. Yep. Check all those boxes. So every time the community has asked us to do something, we find a way to make it happen.
And are you still receiving community bonds? And
Yeah, we're on our last millage right now. So so there's advantages and disadvantages to everything, right? All the other Act 47 hospitals that existed have either closed or they have
sold.
or became part of larger systems. So we're the only one left.
That's incredible.
And so, one of the advantages was the ability to go out and get this, for the millage. So some of the organizations or some of the hospitals did the millage as a operational millage. We never did that. We only did it as capital.
That's a smart move.
Yeah. So and the individuals that set this up, that started all this way before I was ever born, probably had no idea that what we have now is, the decision they made is what we're at now, right?
Yeah.
So, but one of the disadvantages of that is that as a governmental kind of unit, you cannot take private funding. You can mix public and private, right? So anytime, and as capital gets more expensive and you want to do things, anytime you do something, you take on all of the risk.
100% of it.
And, that is good, bad, or indifferent. And, what we found is that, all we could do is vendor relationships. And back in 1945, there was no such thing as a joint venture relationship. So having those conversations, we want to be able to provide the best service humanly possible in our community. We want to be able to, be diverse like many other organizations are when it comes to specialty services. And so we last year went to the community and asked for their permission to transition from the Act 47 hospital to a 501c3. And at a vote of 70-30, they approved that.
Wow.
Yeah, so we think while we will no longer be able to go to the community for a millage, we feel like our partnerships will allow us to do the things that we want to do.
To leverage it, absolutely.
Yeah, I mean, we're looking at adding a Da Vinci robot here, and it's like if I don't have a partner with that, it's just a really expensive,
It's an expensive
piece of equipment,
Yeah.
right? So if we want to continue to like push
Right.
the envelope, this is one of the
Well,
things
that's
that
smart.
yeah,
That smart sounds like the community is supporting it.
Absolutely.
70% is very good.
yeah.
And then you still gonna have a 20-member board.
So with that
That's
comes it's going to be changed up a
Good.
little bit,
Good for you.
and so
'Cause that's rough.
Yeah, and we put safeguards in place because they're the community is really proud of their independence. They're
Right.
really proud of their hospital,
Right.
and so we actually kept some of the Act 47 board in place,
Okay.
and essentially and so they appoint an individual from each community, from each township, and that township then the hospital cannot be sold without their approval.
Right. Right.
So we have kind of a traditional 501c3 board, and then we have kind of a second layer in
Okay.
case we want to do something drastic, like
Still
go away
drastic.
from
Yeah,
healthcare or anything else.
Right.
So
Which anything is. Well, congratulations. It's a lot of work. It'll put a lot of opportunities before you, though,
Absolutely.
that you would never have had prior to that. And you can solicit funds both at the federal, state, and local level, as well as look at grant partners and some other
Yep.
things. So congratulations on that.
Thank
All
you.
right. Time is escaping us, but I have some very important questions to conclude our
Absolutely.
interview today. First of all, you are an active member of Michigan
Yes.
Health and Hospital Association. They do a great job, I think you would agree. MHA does at leading our hospitals throughout Michigan. I believe, aren't you a lead on one of the councils?
Yes.
Which
Yep.
one are you on?
So I'm on the Council for Community Access and Healthcare Impact. Yeah. So
All right. Well, congratulations. I often hear your name at MHA as
Thank
a
you.
board member of the great things that you're doing. So keep it up.
Thank you.
And then we're going to dive into something very political and gross and nasty. And it's like we're facing some of the most difficult challenges in our industry right
Absolutely.
now. Unprecedented times. And there's been some legislation, both federally and statewide, that have impacted our business and will impact our business into the future. So let me ask, what is your perspective on that current state of legislation and policy for healthcare? And, we start off by talking about the federal concerns and issues that have been raised over the course of the last, I'd say, 6 months, that we started hearing about the One Big Beautiful Bill that was going to cut provider tax and have some significant impact on our reimbursement. That's at the federal level. At the state level, a lot of things that we're tackling. They're going to cut us $3.4 billion. MHA was successful in negotiating that down to no cuts, essentially. 340B challenges are facing us right now. But, how are you approaching advocacy from your rural hospital relative to some of those things?
Yeah, I mean, I've been fortunate to advocate at the state level and the federal level, like lockstep with, MHA, other rural partners, Center for Rural Health, our National Rural Health Association. So I've been able to kind of do all of those things, and I've learned a lot in a relatively short period of time. For me, what I've recognized is that everyone wants to do the right thing. Like people are truly, I think they really want to advocate for their constituents. What I've also recognized is most of them, if not almost all of them, have no background in healthcare at all.
Yeah.
And, recognize it as a huge part of, the financial situation for the state and the country. So really what I've done a lot of things that like we did today, just talking about, the importance of what we're doing. And, I think I said this multiple times about how rural hospitals are kind of, not only important from the health and wellness, but just the economics of between that and schools, they really are imperative to have a strong community.
Yeah.
And so telling a lot of stories, making those stories very personal.
Mm-hmm.
Most people, they want to, especially in Northern Michigan, they want to visit Northern Michigan. They want to travel to Northern Michigan. It's a beautiful place. We want that as well. And, when you have an issue, you want to be able to have access to care.
Mm-hmm.
I also tell the story a lot about, I grew up in a small town. Everybody was in it for the right reasons. We all worked together.
Right. You had to.
You had to. You didn't have any choice. And those people were not only just working for their families, working for their families, working their friends, but they were working for the greater good of, the state or the country.
Mm-hmm.
And those individuals deserve access.
They do.
They shouldn't be, I grew up in a space, again, right around when the internet was starting to come out, way before Amazon. And I always thought like, man, I'm being like kind of ripped off here. You know what I mean? Like if I want to go get something, I got to go, 40 miles to get something.
Right.
And as I've gotten older, I realized that, those things that are so important, healthcare is as important, if not more important, for those individuals. And, again, I just continue to talk about, and I know that, I've heard this story before where you've had, the two legislators, one from an urban space, one from a rural space, and the urban legislator says, well, why don't all the individuals just come to the urban space for healthcare? And then the individual from the rural space says, well, why don't you grow your own food then?
Yeah.
And it's like,
No,
when
it's
you
true.
start thinking about it, it's like they do provide the food and the fiber and the fabric for this country.
They do.
And as hard as they work, they deserve access. There should not be disparities in care. People are people, they're important. And, so I just continue to try to advocate and tell the story, not only through my lens as an administrator, but also, my lens as a person who grew up in a rural community that cares about the individuals that are in those communities.
Yeah. So there's a lot of financial headwinds that we're facing right now. Impacted solely by what the government does. Not even payers. We used to fight and worry about payers. Now it's what the heck's the legislature going to do? Especially carving back percentages that we get under provider tax and doing some other things, stripping 340B.
Yeah.
I'm not even sure if you participate in 340B or not, but we're talking hundreds, millions of dollars for hospitals and systems that could be eradicated. So, a lot of challenges around financial headwinds. How do you feel you're positioned as a hospital where you are?
Yeah, I think we're in a good space. We have strong financial gurus that can understand how to make sure that we check all the boxes. When I started, I didn't have a lot of experience in rural healthcare when I came over. Started right before the pandemic, and the only thing I knew about rural healthcare is that there was very slim operating margins. That's about what I knew.
Yeah.
And I remember
finding that to be the truth too,
and using the pandemic as an example, everyone was like, "How is this going to go?"
Yeah.
And I remember turning to the CFO, and he either had a lot of confidence or he displayed a lot of confidence and said everything's going to be okay. And I said, "All right. Well, I've committed. I'm in. Let's do this." And we were foot on the gas the whole time.
Wow.
I think the thing that I love about rural healthcare is that you have to be innovative and creative to be successful. If you're standing still, you're going to fall behind. And so I think, larger hospital systems where the pace of change is extraordinarily slow, I feel like they may struggle with some of these changes even more than the rural hospitals. A lot of the stuff, unfortunately, I feel is short-sighted, right? I talked about how, people want instant gratification, and I feel like some of these cuts are super short-sighted. They have potentially a 4-year window to get something done.
Yeah.
And this stuff is, again, it's a marathon, not a sprint.
Yeah.
And so, continue to advocate about, I talk a lot about the generational impact. It's not the impact it's going to have on me. It's the impact that it's going to have potentially on my kids.
Absolutely.
And potentially on my kids' kids.
That's right.
And that's really what I think we should be focusing our attention and energy. So, I continue to tell the story. I think, we're financially, we have a lot of uncertainty. We're looking at a couple $1 million loss per year that we got to try to figure out how to
figure it out.
And when you're doing services that are not billable, like a community paramedicine, those things are at risk.
They are majorly at risk.
I feel comfortable because I feel confident in the creativity of the rural space. Yeah. But it feels like
a lot of work.
It's unfair.
Yeah, it is. It's disproportionate.
Absolutely.
Is what we would call it. Yep. But you're fighting the good fight, my friend.
Thank you.
You're doing a phenomenal job. Keep up the great work. Continue your advocacy. Be that voice out there. Be the face of your hospital, but you're the face of rural as well.
Sure.
Continue to keep that up. This podcast will go out throughout this country. If you're listening today and you want additional information about what you heard today, we'll put some in the show notes, some contact information for Jeremy. And Jeremy, it's been great to have you on this program. And it's important to tell our story. Rural stories like this are powerful. And the impact that we have in our communities are just second to none. And so keep up the great work. We like to close with a segment that we do called Rural Health Recommendations. And for every guest that we have on the podcast, we always like to just ask them to contribute a recommendation or, living in rural life, dealing with healthcare as young leaders, maybe some sage advice about how they can survive dealing with these new challenges that we're facing. And then we give these recommendations as a separate category for us on our podcast. We'd love just to hear from your perspective on what is your rural recommendation that you would give to maybe a new aspiring leader? Maybe it's someone who's just discouraged today about rural health, or maybe it's just something in general.
Yeah, I mean, I think what I've learned is that you can grow in rural healthcare. That things that in an urban setting that would have taken me, 400 meetings and 4 months to get done, I can get done in 4 hours, and I can see the tangible impact immediately. And sometimes when you're living it, you don't recognize it, but it's always important to take a step back, and
Absolutely.
then you can count the number of times that you made a significant impact, and that impact has a ripple effect right outside the front door. So,
Sure does.
for me, you can grow in rural, you can grow, from an administrative, from a frontline staff, from,
Anywhere.
non-clinical, and
it's amazing.
and you can make an impact on people's lives, and you can see it. In the urban space, you take care of a lot of people, right?
You do.
And sometimes it can be impersonal, but this is like, I mean, I can't tell you how many times somebody, came up, gave me a hug because I did one thing that was just my job.
Right.
But it's so impactful, and the people are so grateful for
Appreciative
that
of it, aren't
opportunity.
they?
It's just amazing.
And they see you at grocery stores, gas stations, places like that. And that's when you know it's purpose-driven work.
Yep.
And you're certainly doing that. Again, keep up the great work, my friend. If you're listening today and you're a hospital that says, I don't know if we're going to make it, there's opportunities, there's encouragement, there's programs that are available, opportunities like paramedicine that might cost your organization in the initial startup, but long-term could have some major impact on the delivery of your care. If you're interested in learning more about this, we'll put in our show notes contact information for Jeremy. He's already consented that he would speak with you, and we would just encourage you to reach out and to thank our listeners for joining us today and tuning into Rural Health Today. It's very important that we have listeners that can support this program. And I would encourage our listeners to catch our next segment, Rural Health News, to stay up to date on current state of rural health care every Monday, wherever you get your podcasts. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you're subscribed to the show so you never miss an episode. Until next time, remember the power of rural.